I'll kind of talk you through my thought process in terms of how I try to put all this together and synthesize an understanding of the pathology and indications for the procedures. So it's an enlightening thing to think about that in Tom Bird's study, 60% of athletes undergoing hip arthroscopy were initially misdiagnosed, and they stayed misdiagnosed for an average of 7 months. So if you just think about what that means to you, that means you start having pain, you see a doctor, you don't get the diagnosis, you go through conservative treatment or some kind of treatment for 7 months until you wind up with the diagnosis. There's another study I didn't include on here that showed an average number of doctors seen before diagnosis was 3.5. So if you've ever seen more than one doctor for the same problem, if you've even seen 2 doctors for the same problem, you know that that's an awful lot of time that you spend in doctors' offices and waiting rooms, and it's a frustrating experience. So getting the right diagnosis is challenging, but is obviously critical. The second study on this slide is that surgery on the wrong site had been recommended in 17% of patients. And that's a staggering number if you think about what it means. So that means somebody had pain coming from a hip problem, but they were diagnosed with something else. They were diagnosed with a spine problem and recommended spine surgery, or with a hernia and recommended hernia surgery. I've even had one patient who wound up in a urologist's office and had groin pain and was recommended a spermatic cord nerve stripping. I'm not even sure what that is, but I don't want one if I have a hip problem. So staggering numbers that I think highlight the fact that diagnosis is not only critical, it's also challenging. So the location of hip pain is variable. The classic C sign that Tom Bird described best is when the patient takes their hand, cups it like a C to the side of their hip to indicate where the pain is. But although this is common, it certainly doesn't encompass all hip problems, and patients will present with pain all over the place. I think the reason is that our bodies, our minds, don't do a very good job of localizing where pain is coming from when it's hip pain. So they may feel pain around the front, the side, the back, radiating down the leg. I was always taught in medical school and through residency that if pain radiates below the knee, then it's coming from the back. That's actually not true, and I've learned that to be not true. So hip pain will absolutely radiate below the knee many times, often as far as the ankle or the foot. So no surprise then, the hip can mimic many other things, and other things can mimic the hip. Some of the common misdiagnoses of hip problems include groin pulls, hip flexor problems, muscle strains, sciatica, bursitis, and hernias. So these are some of the diagnoses that patients may get treated for a long time before they get a diagnosis. I'd like to tip my hat to my mentor, Frank Jobe, who taught me many things, but one of his quotes was, "The diagnostic gold standard is still the history and physical. The MRI helps convince the patient, not the physician, that there's a significant injury." So never more true than in the hip, where physical examination is uniquely challenging. This is not how you do a physical examination in the hip. You learned that already from other speakers. But the examination is challenging. The whole assessment is challenging. So here's how I think through it. The assessment of the hip joint is succinct, but the hip region can be complex because of coexistent diseases, secondary disorders, and coincidental findings. So coexistent diseases, some of these are from Tom Bird. Coexistent diseases can include hip and lumbar disease, and we've done quite a bit of work at the American Hip Institute on the hip-spine syndrome and the relationship between hip and lumbar spinal problems. Coexistent diseases like sports hernias. Sports hernias are often not an isolated problem. They may occur in conjunction with a hip problem because a reduced hip range of motion causes compensatory pelvic motion and increased stress on the pelvic stabilizers. Secondary disorders. A lot of patients will get trochanteric bursitis or gluteal symptoms. If you're aware of Hilton's law, it says that pain may be felt in any muscle that's crossing the joint that is affected. So in the hip joint, there are 27 muscles that cross the joint, and therefore pain can manifest in a wide variety of locations. when we poke on the greater trochanter and it reproduces the pain, once again, I was taught in medical school that the diagnosis is then complete and it is trochanteric bursitis. Obviously that is not true. A lot of trochanteric tenderness will manifest as a result of an underlying disorder of the hip joint or of the gluteal muscles. Snapping iliopsoas tendon. This can be confounding because patients may feel a snap, other patients may feel like their hip pops out of place. Sometimes it's pathologic, sometimes it's not. So a painless snapping hip need not be a pathologic finding. However, when it becomes painful, then it certainly can be part of the pathologic picture. So, to sort of break down a thought process or one approach that you may use in the assessment, I try to think through 4 questions here. Firstly, is the pain coming from the hip or something else, like spinal radiculopathy, hernia, or sports medicine, or muscle strains? And here, a diagnostic injection can be helpful, along with in the next question, is the pain intra-articular? So if it's coming from the hip, is it inside the joint, as in FAI or a labral tear, or is it extra-articular, as in internal snapping, external snapping, trochanteric bursitis, or gluteus medius tears? So if we do a diagnostic injection here, we put lidocaine in the joint, we keep the patient in the office for about 30 minutes after the injection, and we re-examine them 30 minutes after the injection. If they have relief, then we can say that at least some of their pain is coming from an intra-articular source. If it's more complex, if there are multiple problems, some intra-articular and some extra-articular, then we might ask the patient what percent of your relief what percent of your pain was relieved with the injection. And if half of their problem is coming from the hip and half of their problem is coming from the back, then we might expect that 50% of their pain would be relieved with an injection to the hip. We can't use injections elsewhere with the same diagnostic efficacy. So, for example, an epidural steroid injection cannot be used as a diagnostic injection because an ESI can affect hip pain. Steroid injections in general have some systemic penetration of the steroid. So a steroid injection in the trochanter or in the spine may make everything better. So that's not of diagnostic value the same way that an intra-articular anesthetic injection is of value. So if it is intra-articular, can the problem area of the hip be localized by a physical exam? Once again, we're hanging our hat on our hands to figure this out. So are there specific areas of impingement, provocative tests, or instability that may allow us to discern exactly what's the problem inside the hip joint? So let's talk through a case, and I can sort of illustrate this thought process and then take us from the thought process of assessment to the indications and how do we decide what procedures are indicated. So this is a 21-year-old professional baseball player, injured his left hip when he dove into a base. He had anterior groin pain, which was worse with walking, sitting, and hip rotation, and had internal snapping. On physical exam, the range of motion was limited. He was tender over the iliopsoas. He had positive anterior impingement sign. On x-rays, which you've seen from Dr. LaRue, here's an AP pelvis. He had a crossover sign and an ischial spine sign. These are indications of acetabular retroversion. He had a rather dramatic cam lesion seen best on the Dunb view, but also seen on the cross-table lateral view. On MRI, he had a pronounced labral tear. And on 3D CT, we could visualize this cam lesion very well. So in thinking this through, then, you can ask yourself the following questions. So I'll give you 3 more questions. These are the indications questions. First of all, what is going on that made this hip go bad? What are the underlying problems? Secondly, what are the actual pain generators? Now, in answering that question, you have to choose structures that have nociceptive nerve fibers. Cartilage, for example, does not. So you have to choose some structures in the hip joint that you think have nociceptive nerve fibers that are the pain generators in this particular problem. And then the third question is, what do we do to address number 1 and 2? So ideally, we'd like to address both cause and effect and address the pain generators as well as the underlying causes or predispositions. So what is going on? This patient had a labral tear. We've established that by MRI. The labral tear was probably the pain generator or the primary pain generator. As an underlying cause, he had pincer type impingement, which is an impingement caused by an overhanging anterior acetabular lip, in his case because he had a retroverted acetabulum. and it'll cause primary labral pathology, and secondarily patients may develop articular cartilage breakdown. So dynamically, here's what pincer impingement looks like. It's a collision between the femoral neck and the overhanging acetabular rim. He also had cam impingement, which was impingement from a bony prominence of the femoral head-neck junction, and that causes a primary labral tear and cartilage damage. So here's an aspherical femoral head, and here's the impingement that it causes during joint motion. We believed he had Iliopsoas impingement. So he had a painful internal snapping hip, and on arthroscopic examination, there was a direct relationship between the crossing iliopsoas and the labral pathology at the iliopsoas notch. This is a unique area for labral pathology because labrum at the iliopsoas notch should normally not be very affected by femoroacetabular impingement. However, in a snapping iliopsoas, this iliopsoas, we believe, may cause abrasion directly over that area of the labrum. We presented on Iliopsoas impingement back in 2009 as a newly identified cause of labral pathology, and subsequently published that in 2011. So in terms of addressing what is going on and what are the pain generators, we now have to ask what needs to be done. We want to address both pain generators and the underlying cause or predisposition. So this patient underwent an arthroscopy with a labral base refixation, an acetabuloplasty, a femoroplasty or osteoplasty, and an iliopsoas fractional lengthening. There's his labral base refixation repair, and here's the femoroplasty, and as I mentioned earlier, we shoot for a spherical femoroplasty, trying to carve a sphere out of the femoral head. This is his post-operative x-ray of the pelvis, and we see we've trimmed back the acetabular rim. In this particular case, we've eliminated the crossover sign, although I would emphasize that is not always the goal. We don't always want to eliminate the crossover sign, but that's how it worked out in his case. And here's our femoroplasty. I showed this slide earlier, same patient. That's the aspherical femoral head, and this is a spherical femoral head after we've performed the femoroplasty. And we want it to look spherical from every radiographic view. AP, done view, cross-table view should all look round. So this patient began stationary bike on post-op day 1 and returned to competitive baseball at 3 months post-op, which is early, but he was young and recovered quickly. So an outcome that we're all very happy about. A lot of people are attributed with this quote, but actually it's Plato. So every orthopedic surgeon who's ever taken credit for this quote did not say it first. The eye sees only what the mind knows. That's a typical Midwestern hunter not finding what he's looking for because he's not looking in the right places. I think we had a nice quote from Otto Ofrank. Tell me that again.
I screwed up. Read it.
So similar quote illustrating this point that we can't find things that we are not aware of. And I think diagnosis is critical. It is harder in the hip than it is in the shoulder and knee. It takes more effort and more workup. And I think the effort certainly pays off and is worthwhile. So thanks once again, and I'll yield to the next speaker.